welcome. And I see a few familiar faces from the last time we were here. And so welcome back, everyone. This is Sherry Larkins, and I'm at University of California, Los Angeles. I'm visually wishing that I was, in the Caribbean somewhere, but, I'm just in my dark bedroom here instead. I'm joined by our Azusa Pacific colleagues who are running all of this. And so I want to thank all of them. And we're also joined by Dr. Matt Torrington today. Last week, you know that for those of you who were on, we were joined by Dr. Brian Hurley. And I would say we have basically the two biggest experts in LA County, and Matt, probably the United States. He's probably seen more buprenorphine patients and methadone patients than most practitioners. And so we're thrilled to have him join today. As I mentioned, last week, we went over some pretty standard stuff about buprenorphine, things like, how to kind of prepare your staff and your site, but also what does a standard induction look like? What do follow-up visits look like? And today is a bit more specialized. Today is it's going to be very experiential based, and we're kind of hitting on 4 topics that a lot of new practitioners often have questions about. And that can range from anything from, what do I do with a patient who seems to have like chronic pain? What about a patient who's going in for surgery? What about a patient who wants to taper, who's thinking about getting off the medications? Who's a good candidate for that? And who isn't a good candidate for that? And if someone is tapering, how do we do that most effectively? And also, how do we work with women who are pregnant? You will come across women who are pregnant, who become pregnant, and you'll want to know how to best handle their medications at this time. So those are kind of the areas that we're focusing, sort of really clinically on that. So Matt, I'm going to let you introduce yourself. There's Matt's adorable picture there at the bottom and a bit of a bio on him, but I'll go ahead and let you introduce yourself.
Hi, everybody. I'm Matt Torrington. I'm a family medicine doctor with a specialty in addiction medicine. I have a background in clinical research and medication development. And my buprenorphine story started way back in 2001-2, when my very first job in LA was working on a clinical trial looking at pain tolerance and pain threshold on controls versus methadone versus buprenorphine. At that time, buprenorphine was not yet FDA approved for opiate use disorder, and being part of UCLA's integrated substance abuse programs, when it was FDA approved, there were ample opportunities to learn and teach, and I've stayed pretty involved in buprenorphine since then. Now my clinical practice is focused mostly on the longitudinal disease management of addiction and pain, and that's me in a nutshell.
Matt, you bring up a couple of good points about, especially topics like pain that you mentioned a few times. It's important for you guys to know that while we're here today, each of the topics that we're talking about, whether it's like caring for women who become pregnant or pain management issues or tapering, each of these are topics that Matt could probably spend like a solid few hours on each of these topics. And so what we're doing today is really just sort of a brief survey at the very surface level. We'll be able to provide more resources for you. And if it's of interest to you to get more information, we'll certainly provide that. But today's kind of a bit more of the anecdotes and sort of just the real sort of surface level information to get you guys started. So thank you, Matt. So we kind of started a little bit last week talking about some of the organizational aspects of starting an MOUD or starting medications for opioid use disorder, something like buprenorphine. And there's a lot of organizational readiness stuff that sometimes happens when you start a program, or maybe you're walking into a program as a nurse practitioner where they're already doing stuff. But there are a lot of procedural things, and we talked about some of that last week. But we're actually moving from sort of organizational, and now we're really focusing this week just really on patient care and how to deliver good quality care to patients with opioid use disorders. So what I'm going to do is I'm going to first, kind of hand it over to Matt there are some recommendations and some sort of standards in the field about, what happens when a patient gets pregnant? What do you do with them if they're on buprenorphine? And I think early on there was certain recommendations because we didn't have a lot of science on that, but I think things have become a bit more simple in terms of recommendations for folks who are pregnant. So Matt, I'm going to turn it over to you now. You have a patient, a client, they become pregnant. What's your experience, and what do you sort of recommend for those patients?
So, pregnancy is one of the most fascinating and intense times in anyone's life. And if it's complicated by history of opiate use disorder, the need for the patient to stay sober and to stay well is never more important than during pregnancy. And it's a hypercharged time for mom. And so one of the things that we think about is that, number one, if your patient is already stable on maintenance treatment for opiate use disorder, keep them stable. Certainly recommendations are that we should use mono product versus buprenorphine naloxone. And the idea there is just like, why add another compound if it's not absolutely necessary? But there are plenty of patients who were maintained on buprenorphine naloxone and did okay, but that's certainly one thing you can do. The other thing is you have to understand that as pregnancy goes on and the metabolic changes associated with pregnancy can require dose adjustments. Occasionally doses go down. Sometimes, most often, doses go up. A lot of times, doses stay the same. It just depends on how the patient's doing. And when it comes to dosing in general, I am a flexible doser. I'm always striving to have my patients take the minimum effective dose. And that's exactly the way I describe it to them. I'm like, I want you on the dose that blocks your craving, that prevents you from having withdrawal, and that has the minimum side effects. The greater the dose, the more chance of side effects. And so we really want to make sure that people have a dose that's going to be adequate to block their craving and withdrawal, but also that, is as small as it can be reasonably. So those are big picture things.
Matt, really quickly, you mentioned mono product, and I know most of the folks have done some level of, or are going to be taking the X-Waiver training, but haven't yet. But we did kind of talk about this a little bit last week, but the mono product is just straight buprenorphine without the naloxone added, correct?
Correct. So, and it was formerly known as Subutex, and that word gets used quite a bit, although there is no more brand name Subutex. And that Suboxone, although that what was originally Suboxone is no more, and now there's only Suboxone branded film. Those are really just brand names that we try and avoid because really the company that, promulgated them sort of bad corporate citizen, and we don't need to give them any extra publicity. But the idea is that like the mono product is just buprenorphine alone, and the combination product is buprenorphine with naloxone. The naloxone is compounded with the buprenorphine just to prevent and deter abuse, misuse, and diversion. And so that when we say mono product, what we're talking about is buprenorphine alone.
Great.
The big picture aspects of treatment for opiate use disorder all are triply important in pregnancy: comprehensive, individualized, multimodal treatment that's biologic, psychological, social, spiritual, and nutritional is what's going to give patients the best chance of success. So big picture things for patients who are pregnant are like you got to coordinate care with your OBGYN. And patients don't want to tell their OBGYN necessarily that they have a history of opiate use disorder and that they're on medication. Luckily, stigma and acceptance in the OB world in our environment is much better than it's ever been, and that patients who are upfront about this on the front end always seem to do better than ones who never tell or get found out at some point with the drug screen. So it's really important to try and then coordinate care with the OB and to advocate for your patient, to humanize them and to try and help them have a good experience. Okay, that's really important.
Great.
The other thing is that you want mom to quit smoking, right? There's a huge concomitance between opiate use disorder and nicotine use disorder. And if mom's smoking, that's a really bad risk factor for the baby. So we really want to focus on that. If she's drinking at all, there's no safe amount of alcohol in pregnancy. Okay, and we really don't want our opiate use disorder patients drinking either. Okay, so this can be a teachable moment. And then also, like, people are worried about social services. In California, it's not a big deal. Like, what's a big deal is if mom tests positive for cocaine or methamphetamine or other drugs of abuse. So we really want to make sure that if you have a prescription for the drug that you're taking and you're if you're under the care of a treating physician or MP or PA, that's acceptable. And social services is not going to give them a hard time, and it's going to be okay. Also, mom's going to be really worried about neonatal abstinence syndrome, right? Which is a real thing, right? But remember, neonatal abstinence syndrome is always going to be worse with methadone than with buprenorphine, and it's going to have something to do with the dose of buprenorphine. So the higher the dose, the more likely there is to be neonatal abstinence syndrome. And in my N of like 8, because I've had eight women who got pregnant while they were on buprenorphine and had babies. None of their children had clinically significant neonatal abstinence syndrome, and none of them had to go to the NICU. Sometimes, this is not based on data, this is based on my anecdotal feeling. I feel like sometimes there's bias, and the NICU is such a terribly difficult place to be that they know that this diagnosis exists. And when you look at the criteria for neonatal abstinence syndrome, some of those criteria are pretty subjective. I think that sometimes that stuff gets a little bit exacerbated, and that you get those really high cost days in the hospital sometimes. Now, sometimes it's really serious as well, but either way, we've got to make sure that mom is being upfront with the whole team, that care is coordinated, and that we're helping mom develop and implement a comprehensive plan. Next slide.
Great, great. Let me see if I have any. Okay, perfect.
Yeah, well,
Another question is around surgery. Sorry, I kind of asked you those questions, I think.
well, it's very
fairly.
typical for pregnant patient. Okay, so describe a fairly typical case of pregnant patient. Walk us through the clinical management. So suppose you got a patient, they've been under your care for about a year, they're stable on, say, 8 milligrams of buprenorphine naloxone, and that they're like, oh my God, I just got pregnant. Okay, cool. Amazing. Like, so the first step is going to be, you need to get in to see an OBGYN. We can switch you to mono product, to buprenorphine alone. We can help them understand that they're going to be, that the mono product is probably going to behave very similar to the combo product, but with all these different generic formulations of buprenorphine that we're working with, there can be real product to product differences. And so if your patient says, they gave me a small pill and it worked really well, and then they gave me a big pill and it didn't work as well, listen to your patient. Okay. It is possible that they're having trouble absorbing the medication sublingually, or that there are differences in the generic formulation that they're getting. Adjust the dose to effect for your patient.
Right.
And I would say the one or two most important tips to prescribers who are managing a pregnant patient for the first time are: number one, maintain your empathic, non-judgmental attitude. Maintain your firm belief in the patient's ability to succeed, and pump them up about doing a great job for taking medication for their disorder and for managing their problem in a responsible way that makes sense. Okay, that'd be good. That's what they need. Okay, and then also coordinating care and encouraging the most coordinated care strategy possible, because those are the things that are most likely to be helpful. And then also striving to take the minimum effective dose, and knowing that as pregnancy goes on, that there is the possibility that you may have to modulate your dose, especially in the second and third trimester.
Great, great. So when it comes to surgery, and this is going to be sort of acute stuff, you have a patient who, has appendicitis and they need to go in for surgery right away, or somebody's getting a root canal and things that, um, cause pretty acute pain, and yet they're already on an opioid that has sort of a ceiling effect. How do you manage a patient um, who is going to experience pain, and so that you don't sort of overdose them in some way? So I'm thinking of the things that clinicians might be worried about here. What are your thoughts about that, and what's your experience when this happens?
Great question. So when it comes to surgery, we learn about this from our patients, right? And again, back to stigma. A lot of people in treatment for opioid use disorder do not want to tell anyone. They do not want to tell the dentist. They do not want to tell the dermatologist. And so what happened was, a lot of these patients have had these small surgical procedures, and they were on treatment with buprenorphine, and then they got dosed with 3 hydrocodone or 3 oxycodone or 3 codeine. And what they found is that they got pain relief from those medications. And when we teach that buprenorphine blocks subsequently administered opiates, we really should say buprenorphine blunts subsequently administered opiates. And what it really does is it blunts euphoria from subsequently administered opioids, but it does not blunt analgesia. So if you're on a moderate dose of buprenorphine, you can take some full agonist on top of it and get analgesia without having to go through the trouble of getting all the way off of buprenorphine, getting on a full agonist for pain, and then going back to buprenorphine. Now, if the patient is going to have a very serious surgery where they're likely to have a lot of postoperative pain, and they don't seem to think that buprenorphine is very helpful for them for pain because, different patients have different responses to different analgesics, it may make sense to stop buprenorphine, to go all in on full agonists, to manage aggressively with full agonists, and then go back to buprenorphine. That's okay. Okay. It's also possible that you can stay on a moderate dose of buprenorphine and then add full agonist as needed for 1 or 2 or 3 days, and then go back to just taking buprenorphine. That's okay too. It's also possible to just try taking more buprenorphine, right? You may be able to increase the buprenorphine dose and get adequate analgesia. Also, many hands make for light work. So if you attack the pain, whatever kind of pain it's going to be, from multiple angles with Tylenol and ibuprofen and topicals and ice, and changes in behavior, sometimes that combination can be more powerful than just trying to treat the entire thing with a whole bunch of high intensity full agonist. Those things can make a huge difference. And really, the group at Stanford with Anna Lemke, they have written extensively about this and really done a great job of creating protocols for their team about adding more buprenorphine or adding supplemental full agonists to the buprenorphine, and managing these patients, but really one patient at a time, navigating their individual needs, and also making sure to coordinate care with the anesthesiologist and the surgical team to make sure that they're on board and that everybody's on the same page. Many times, those are the kind of strategies that are most effective.
Do you find that, so I said, walk us through sort of the clinical management of a patient with an upcoming, and you hit upon some of this, but what is your experience with coordinating care across specialties? I heard you kind of mention that there's sometimes such stigma that they're like, oh, I don't want to tell my dermatologist or my dentist.
They don't, and sometimes they won't. And that's basically like that. I'm not going to force that issue necessarily unless I absolutely have to. Obviously, if the health and safety of the patient is at stake, HIPAA is not in play. So patients are like, you can't tell. Well, you can, but you really don't want to alienate your patient if you don't have to. So if suppose the patient's going to have a minor root canal, and they've got their dental chicken and they're really worried and they're like, what should I do? I say, hey, keep taking your buprenorphine, take whatever they give you, don't worry about it. And then think about it from a pharmacologic standpoint, like they're staying on buprenorphine, so they're unlikely to have severe craving or withdrawal, and that they're going to get some effect from the full agonist that gets prescribed, the 3 or 4 or 6 Percocet that they get, right? And by the way, like, they don't have to worry about stopping buprenorphine, restarting buprenorphine, any kind of titration or taper. It's generally a non-event. So that's one possibility. The other possibility is the patient's going to have something that's really serious, like they're having a knee replacement, which sometimes can be very painful for a long time. Oh, and they already had one knee replacement, and last time they were in a tremendous amount of pain for a long time. And a lot of times for those kind of procedures, the PT wants them on full agonist so that they can get them to do stuff that they can really only do when they have some really high levels of analgesia.
Right. Okay.
No problem. So in that case, you're like, okay, take your last dose of buprenorphine the day before surgery. Okay, make sure that they know what you're on going in, and that so that they can add to your postoperative pain management a certain amount of opiate just to keep your opiate receptor saturated and keep you from going into withdrawal, and then give you supplemental opiate as needed for pain. Because for somebody who's coming off of buprenorphine, they're going to need a certain dose of full agonist just to stay well. And then they're going to need even more to get analgesia. And so it's really important to make sure that people understand that so that the patient isn't given less medicine, right? Many times, patients with opiate use disorder get exactly the opposite kind of care that they need because they have reduced pain tolerance and they have higher tolerance to medication, right? So they experience pain more subjectively and worse, and the medicine does less for them, and they get the least amount of medicine, when in reality, they probably need the most medicine. Okay. And so we have to make sure that we coordinate that with the anesthesiologist and the postoperative team so that they can customize the regimen to meet the needs of the patient.
Now, Matt, do you ever worry or do you have concerns? And of course, this is coming from a, behavioral health person, not a medical person, but when they have concerns about something that's minor and they don't really want to coordinate with their dentist or their dermatologist, and you mentioned, is there any reason why you have to worry that they can overdose on, a dentist is going to give you, two Vicodin a day or anything like this? Is there any reason if they were taking their doses prescribed by the doctor that on top of the buprenorphine, you don't have to worry about sort of overdose or anything like this?
Not necessarily. I really don't think so. The risk for overdose for buprenorphine is always polypharmacy and is always benzodiazepines or alcohol or
Got
both
it.
plus buprenorphine. And
Got
think
it.
about it. If you're on full agonist and you take buprenorphine, it's going to precipitate withdrawal,
Yes,
right?
yes.
It's not
Right.
like if you take full agonist on top of partial buprenorphine is protective,
Right,
right?
it's
Because
got
it
that
has a
protection there, right? Okay.
has higher affinity to the receptors than the full agonist. Now, if you add super high affinity full agonists like fentanyl, carfentanil, N-acetylfentanyl, remifentanil, that's a different story. But those
Got
aren't
it.
things that we're commonly using in this setting. And so,
Right.
really, we don't think there's any reason to think that that's unsafe. In fact, in my perspective, the patient is safer staying on buprenorphine and then adding some full agonist than stopping buprenorphine
Right.
and then having their unsaturated receptors affect their limbic brain. Because remember, when your opiate use disorder patient is hungry for drug, they're hungry for drug the way I'd be hungry for air with a plastic bag over my head. They're starving to death for drug. Their brain is giving them starving to death signaling the way my brain would be telling me I'm starving to death for oxygen when I can't breathe. And that's very hard to deal with. So the idea is keep those receptors saturated if at all possible, okay? Because there's no reason for the patient to add being in withdrawal and having a lot of craving to the complications and difficulty of going through surgery.
Right, so as much as possible, it's like keeping patients on their buprenorphine dose, uh, and keeping sort of that maintenance and that stability is like, the first goal. Great.
Correct.
Good. This is helpful. I have up here questions and comments because we are going to move on to the next topic, but Dr. Torrington's here for lots of questions. So make sure that if you have them or if there's things we haven't hit, I tend to ask the questions that I'm most curious about. But I think it's hard for me to see the chat, but I think Ashley and Irene are monitoring the chat. So if you have questions in the chat, please ask them, and we'll make sure that they get to Dr. Torrington. So we talked about this kind of acute level of pain and what happens when someone goes in for a surgery and stuff. There is like a whole entire body of work that's around chronic pain. And I know that you've worked a lot in this chronic pain field, so I don't want to do it injustice by just sort of, but I think it's helpful for new prescribers to kind of understand, when patients have chronic pain, how do you know who's doctor shopping and looking for stuff and who really has chronic pain, and how do you manage that? Or if they're not the best person to manage it, how do they find people that kind of do sort of chronic pain management? Um,
Just
so
ask like 12 questions at the same time. Okay, so
I know
let's talk
I've
about that.
thrown it at
So
you.
the first of all,
Yeah.
if you're prescribing controlled substances in the state of California, you should run a cures report on the patient before you
Okay.
make your first prescription at least every 3 months. And if there's any suspect that there's any suspicion that you think the patient may be getting medication from more than one provider, you can always check it more frequently. And it's a very helpful tool. For me,
Yeah, you Cures is good.
it's a conversation
I
starter,
mean,
right?
Cures,
It's very, very
great.
helpful. So there's that. Okay, number one. Number two, pain is in the eye of the beholder, right? And that there's this, there's huge pushback against, treating pain with opioids, but like people really suffer a lot. And a lot of our other tools that we use for pain don't work that well and can be really difficult to tolerate and can have side effects. So the idea for pain is the same as for opioid use disorder. Your treatment plan should be comprehensive, individualized, and multimodal, and should be biologic, psychological, social, spiritual, and nutritional. Now, the good news about buprenorphine is that buprenorphine is an excellent analgesic, and there are buprenorphine formulations which are just indicated for pain. The Butrans patch comes in 5, 10, 15, and 20 micrograms per hour and lasts 6 to 7 days and provides a really significant amount of analgesia very consistently and is extremely safe and generally very well tolerated. And Belbuca is a mucally erosive buccoadhesive that sticks on the inside of the cheek, okay? And that drug comes in 30 or 75 micrograms, 150 micrograms, 300 micrograms, 600 micrograms, and 900 micrograms, designed to be dosed once every 12 hours. And that drug can be used very successfully for pain. And so if you have a patient who's on full agonists and they're not doing well, they may do well with buprenorphine. And if their doses are really high of full agonists, they may need some of the doses that are FDA approved for opiate use disorder, like the buprenorphine naloxone that comes in much bigger doses than micrograms, that comes in milligrams. And that's okay. We really feel like that treating people with chronic pain with buprenorphine is better than treating them with full agonists, mostly because of the ceiling effect on respiratory depression, sedation, and euphoria, and the lower street value of these drugs. And they're just better tolerated. So there's that. Okay. But we also know that if you have a unimodal pain management strategy that's just pharmacology, it's much less likely to be successful than a multimodal pain management strategy. So I love this quote here: opioid debt must be satisfied before any analgesia can occur. This is my point about the surgical patient who we're going to switch to full agonist. It's going to take a certain dose of full agonist just to keep them well. And then anything on top of that is what's going to give them analgesia. So it's really important. And it's also important to have a plan for patients who are getting treatment for their pain and then have breakthrough pain. What are they going to do in that situation? Sometimes breakthrough pain can be managed with NSAIDs. Sometimes breakthrough pain can be managed with a change in activity. If I lie down and put my feet up, the pain gets better. Okay, well, let's do that, right? Instead of like hammering with more medication. Okay, but establishing a collaborative environment with your patient, trusting them, but verifying what they're doing with regular urine drug screens and pill counts and callbacks if necessary. Those are the kind of things that are likely to have a regimen that's going to be successful. And then also, having more oars in the water than just opioids.
Great, great. I'm trying to think. We give you guys a tip at the bottom. There's you'll see on the slides later that there's sort of a video that goes over some intersection of pain and
Okay.
addiction.
We could talk about some of the bullet points here. The half-life of buprenorphine for opiate use disorder is about 37 and a half hours. In one of the very first buprenorphine studies that Leslie Amos did, they only dosed buprenorphine 3 or 4 times a week. Okay. They gave much bigger doses, but they gave it less frequently. When we're using buprenorphine for pain, we're more likely to use it 3 or 4 times a day because the analgesic therapeutic window is shorter than the opiate use disorder craving blocking window. So you want to have more of a tendency to give smaller doses and more frequently. The other thing about buprenorphine that we learn from the buprenorphine only analgesic preparations is that a little bit goes a long way for analgesia. Whereas a typical, dosing for somebody with severe opioid use disorder might be, 8 milligrams 2 or 3 times a day. For pain with even severe pain could be 1 to 2 milligrams every 4 to 6 hours. Okay. And that maybe it may work just as well as 2 to 4 milligrams every 4 to 6 hours. And then again, my strategy for this is all about empowering the patient and trying to get them to be my partner in striving to take the minimum effective dose. Um, Short-acting opioids, in addition to usual buprenorphine maintenance, can be helpful, as we discussed early. And then you can always go back to full agonists if necessary, if it's not working well enough. I think we can go to the next slide.
Great. So I have a question here, and again, feel free to put questions in the chat. Describe a current case of buprenorphine patient with chronic pain that you are also managing, or one or two big tips, or what would you say is the biggest challenge, or what are some of the key tips that you would suggest for people who
Okay,
are
so
prescribers?
suppose it's like you just come to a new clinical setting and you get some new patient who's these are like my favorite people, like some 65-year-old pillar of the community with chronic abdominal pain, who's been on Dilaudid 4 to 8 milligrams 3 to 4 times a day for 5 or 6 years. And you're like, whoa, right? They're not abusing, misusing, or diverting their medication. You feel really confident about that. They've already been worked up one side and down the other of UCLA. You don't know what's really causing their pain, but you know that their regimen isn't really getting them that much. They're getting relief from it, but they're not in a great spot. Okay, so what are you going to do? Well, there's lots of options, but one tricky little thing you can do is you could say, all right, we're going to do what we call the Bernays method. We're going to give you a patch of buprenorphine, 20 micrograms per hour. Keep taking your Dilaudid for the first week or two. What you're doing is you're backfilling a bunch of opiate receptors with buprenorphine, so that 2 weeks later, one Saturday morning, you say, okay, when you wake up, don't take your Dilaudid. Wait until you start feeling a little bit runny nose, watery eyes, dilated pupils, and now take a little bit of sublingual buprenorphine, 2 to 4 milligrams. And for the weekend, don't take Dilaudid, get it out of reach, and just take sublingual buprenorphine. Now, in a very safe way, you've just transitioned the patient from full agonist to partial agonist without having to get a chance of precipitated withdrawal, without having to get the patient really sick, without having to do a serious induction of any kind. And that can be really helpful. Okay, and that it's totally safe to use the buprenorphine patch while they're still in full agonist. Or maybe once you put the buprenorphine patch on, you're like, hey, switch your Dilaudid to as needed. If you don't need it, don't take it. Maybe they're able to dramatically taper their dose, and they're only going to have to take it when they have a serious issue. Now, those are both real world examples that actually have happened. Right. So
Matt, the thing that you've said, I've heard you say this a few times, is like, it's very safe to do this. It's very safe to do this. And one thing that I hear from people who are newly like waiver prescribed, and this is what, not just this series that we're doing now with APU, but more generally, we've been working toward this, is the drop off between the number of physicians or advanced practice practitioners that get X-waivered, but that actually don't ever prescribe, is huge. And a lot of people will say the same thing as, well, I'm not comfortable because I don't feel like it's safe. And they might be really comfortable prescribing a whole bunch of Vicodin or something that actually is much, probably less safe of a medication than they are buprenorphine. But I've heard you sort of say buprenorphine is so safe. How do you work with new prescribers to get them confident that that they're not going to kill the patient? I don't know if I'm asking.
Explain the history. I don't know. I mean, I think it's explain the history, right? Because look, you don't need any special training to prescribe methadone or OxyContin or Xanax, all of which are infinitely more dangerous than buprenorphine in every setting. Okay. But because buprenorphine was new, because we weren't sure, because it was the first outpatient treatment for opiate use disorder in 80 years, we created these artificial barriers, which makes people think that it's more dangerous. And then we limit the number of patients, and the DEA can come inspect you, and you have to jump through all these extra hoops, which makes you think it must be more dangerous. It's not dangerous, it's political. Okay. And since we come from a country that's government makes mostly mistakes, in my opinion, right? Like, this is a mistake. Right? This is not necessary. More education is good for everyone, but this drug is not more dangerous than other drugs in the pharmacopoeia. In many ways, it's much safer than other drugs in the pharmacopoeia. Okay, but the way that it evolved is partly the reason for all this additional training and oversight. And many people don't believe it was necessary. Some people believe it was mostly political, but it's really difficult. Okay, so that's that's a whole separate issue on the safety side. But really, if you just study the pharmacology, buprenorphine is always going to be safer than benzodiazepines or opioids. When you mix things together is when things get sketchy.
One thing I had a question here about, you actually started working on some of the very first buprenorphine trials here in the United States. So you had this sort of long history of working with this, and now there's all of these more mentorship capabilities and possibilities for people. But did you just kind of learn by trial and error? Were there other people, like a few physicians that really knew this stuff that you could check in with? Because I think that's a lot of people's concern is if they're moving into a site where they're the only prescriber or there's only one other prescriber, how do they kind of like learn how to feel comfortable with this? And
I
I'm
mean,
curious about what
there's
yours
the
was.
PCSS program, and there's mentor programs, and there's the California Society of Addiction Medicine and the American Society of Addiction Medicine, and that there's more resources now than there have ever been before. Okay, and so that's really good. There were doctors who were using buprenorphine successfully for pain long before it was FDA approved for opiate use disorder, because Buprenex, liquid buprenorphine, was FDA approved for pain, I don't know, in the 70s or 80s. It's been around for a long time. So it's one of those type situations. I see some questions popping up
I
on the chat, and I think it's worth it to
Yes,
address those.
yes, thank
So
you.
one question is, how much credence do you give to past trauma, psychological and emotional, described in the work of the book The Body Keeps Score, affecting um, chronic pain, and what steps to begin to take? That's why I'm constantly reinforcing the idea that all treatment should be biologic, psychological, social, spiritual, and nutritional. And so, the more you can address the psychological underpinnings of historic trauma, the more likely those things are to be resolved. Those things, in my experience, are almost never resolved pharmacologically, although who knows, with the advent of MDMA and ketamine and psilocybin and some of these other things, which may help us do that pharmacologically. Right now, the only way to address that stuff is psychologically, and I think that that's incredibly important. And I say more is better. And the other question is, why does it seem that patients on IV high potency Dilaudid ask for their medicine more than those on morphine IV? Isn't Dilaudid supposed to be stronger than morphine? They ask for their medicine more than those on morphine. Hard to say. Remember, each person has a different constellation of hepatic P450 enzymes, and we all metabolize things differently. And it's possible that you're giving one patient Dilaudid and they're not able to metabolize it well, so it's not working very well. Or it's possible that you're giving them morphine and they're not metabolizing it very well, and so that they're not getting enough of effect. Or another person like metabolizes the medication incredibly quickly and they metabolize it fast, so it's not working for them. I think I sort of misspoke that. If they don't metabolize it well, it's going to last longer and be more effective. And if they do metabolize it really fast, it's gonna not work as well. And so you want to think about individual variations. And if the medicine isn't working for the patient, consider changing it. And then also, like, just depends on the individual and what they're, what's going on with them. It's hard to say the answer to that, but that's a good observation. This next question says, last year I saw a psych patient who had kratom in her possession. She said it was to prevent cravings and pain. Is there anything in your experience as a natural product versus synthetic? Is it safe? Kratom is a naturally occurring opioid, which is like a weak full agonist, and touted as this herbal remedy, and it's touted as this withdrawal remedy. It's just another weak opioid. And so I've had patients who are like, oh, I'm going to get off of buprenorphine with kratom, and then they're stuck on kratom. And the problem with kratom is it's unregulated. The supply is different every time you buy it. It's very hard to modulate your dose. It's often riddled with inconsistencies and contaminants. And then the price really varies. The quality price ratio varies because it's not an approved drug. So kratom is really just like a legal, weak opioid is the way to think about that.
Right. And the fact that somebody or that people, I guess it kind of really goes to the stigma of, like, they think, oh, well, a medication for this is one thing, but this is a sort of natural way that I can sort of get myself off of something. And you mentioned tapering, which I know is kind of leads into this last topic that we're going to get at. But um, this idea that people, don't want to be on something, or they don't want to be on buprenorphine, that they'd actually prefer a very unregulated, adulterated, weak opioid to self-medicate, perhaps in some cases, over a more regulated medication. Do you have patients, and we'll talk a little bit about tapering, but do you have patients that kind of come to you with this, I don't really want to be on this? Like, what if there's stigma that the patient, him or herself, has, and how do you sort of manage that?
Patient came in today for a Sublocade shot. Sublocade is a long-acting form of buprenorphine, which lasts a month or more. And she's like, I really like this medicine. It helps me, but my friends in 12-step are against it. So I just don't tell them. And what I tell people is take what you need and leave the rest. If your environment isn't supportive of your pharmacologic regimen, like, I don't know what to tell you about that. I'm happy to educate them. I have had meetings with people's sponsors. I've had meetings with people's parents. The reality is, I see opioid use disorder very similar light to diabetes. When patients first get diabetes and they're new onset type 2, we try and get them better with diet and exercise. And when that doesn't work, we offer them pharmacotherapy. And when oral pharmacotherapy doesn't work, we offer them insulin. We don't treat them crappy because they're on insulin. And we don't tell them, well, you can only have insulin for a month or a year, and then you better get off it, or else if you don't get your ideal body weight, I'm going to take away your insulin.
Right, right. If
That's
if
just
I see you
not
eating more cheesecake, the insulin is gone. You haven't
right.
managed your
And,
diet.
and so really, like, we just try and help people not die from the severe life-threatening illness of opiate use disorder. And I think that those old stigmas and those old ideas are really, they're not supported by evidence. And so I try and really think about the evidence, and that makes the most sense to me.
Okay. So that's sort of uh, patients who say they want to discontinue for a variety of reasons. Maybe it's stigma. Maybe they've been on it a long time. Maybe have you had patients that are really good candidates for tapering? And I know that tapering is probably something that's there's a lot of things to consider through this, because just as your diabetes example, you don't want to take people off something that really has stabilized them, where they're doing well and where they have like a level of control or something, or meaningful life that they haven't had in a long time, and then you risk taking medication off board and what that might look like. But I guess you still have patients who really probably want to, and where do you go with that when you help a patient taper? What does tapering look
I
like?
mean, this is an incredibly important aspect of treatment, because you certainly don't want to go down any road where you don't know where the end of the road is. Okay. And so the way I explain it to patients goes like this. Here's the black hole of opiate use disorder sucking you in towards certain death, right? Because we know that of people doing heroin, 1 in 10 are going to die per calendar year. And we've got 70,000 plus people dying per year of unintentional opioid overdose. And that everyone taking any pills that don't come from a pharmacy with their name on it are playing Russian roulette every single time they take one. And so when you take buprenorphine, or methadone for that matter, the black hole turns off and the suction stops. Then your job is to change your life psychologically, socially, spiritually, nutritionally, so that when you stop the medicine and the suction from the black hole turns back on, you're far enough away that you're going to be able to escape terminal velocity. Okay. But some people have a really hard time changing their lives. Some people have a mom who carries around a purse full of pills. Their next door neighbor is a drug dealer. They've got 9 aces. Okay. And that really they can't develop enough momentum to be safe. So they should probably stay on the medicine. Okay. But my point is, the best time to stop the medicine is at a peak of psychologic, social, spiritual, nutritional, and biologic momentum, not the nadir. Okay. And you shouldn't be stopping for logistic reasons or because somebody else wants you to. Right. So we should be making a planned attempt at stopping when you're at a peak of psychosocial momentum. And if you're stopping, the best plan is to taper slowly. And I like to taper slowly to the point is tolerating the taper. Right. So depending on your dose, like if you're on 16 milligrams a day, you could probably decrease your dose by 25% and not notice very much. You can go from 16 to 12, probably not a big deal. But 25% of your dose when you go from 8 to 6 may be a little bit harder. The other thing to remember when you're tapering, right, is that it takes 2 full weeks at any dose reduction to fully absorb the pharmacokinetics of that reduction, right? So 8.5 half-lives before the medicine leaves your system. So if you're at, you know, X dose of buprenorphine, right? And then you make a dose reduction. Before you make the next dose reduction, make sure to wait at least 2 weeks, because otherwise you can be still suffering from the dose reduction A, and then you're on dose reduction B, which can make it much harder.
Wow,
So,
right.
so reduce your dose in 2 week intervals, okay, and then take the drama out of it. And then also, I want patients to be comfortable while they're tapering, right? I don't like to use ancillary medications while I'm tapering. I save the ancillary medications for when they stop. And I taper as slow and low as I can while patients are comfortable. And if they get to the point that they're not comfortable, go back up a little bit, right?
Okay.
And the other thing that can be very successful is alternating daily doses. So you're at 4 milligrams and you're trying to get to 3 milligrams. So you take 4 milligrams, then you take 3 milligrams, and you take 3 milligrams, and then on the third day you're feeling a little destabilized, you're having some physical symptoms. Okay, take 4 milligrams the next day, then go back to 3 and take 3 milligrams for 3 days, then take 4 milligrams for one day, then take 3 milligrams for 3 days, then take 4 milligrams, and then see if you can ride it out. Okay. But the whole point of using whatever tools you can to try and decrease the slope of the taper to make it best tolerated, that can be really helpful. And then also, the more you can do to upregulate people's psychological, social, spiritual, and biologic momentum, the more likely they are to be successful.
Um, I'm curious, and feel free to drop any questions you have in the chat because we only have about 10 minutes or less left with Dr. Torrington. When some real world examples, I mean, have you had patients that you've like tapered over sort of months and just sort of let them sort of stabilize and plateau and then do, or do people, are some of your patients a little more aggressive, like, oh, I want to do this more quickly, or do they really kind of understand that a long, slow taper is going to be to their long-term benefit?
If there are logistic or usually personal reasons why someone wants to taper quickly, it's just a classic opiate detox, right? And that,
Right.
and if you think of the worst flu you can imagine times 10 as heroin withdrawal, buprenorphine withdrawal is the bad cold you wouldn't want to go to work with, but you could if you had to. You feel crappy, okay? But it's not like the worst flu you can imagine times 10, okay? And that really, if you understand what kind of symptoms people are facing and you treat them, people can get through it quite easily. But they're going to do better if they have the help and support of a clinician and some pharmacology than if they're on their own. And obviously, the environment that they're in and the psychosocial pressures that they're facing are going to really play a huge role in whether or not they're able to remain free from their opioid of choice.
And I have one last question about you've mentioned so much sort of the powerful role. These medications are super robust, and we know that. But the kind of powerful and important role of all the other things, the mental health issues being addressed, um, spiritual issues being addressed, and the range of it. Are you finding um, we think of those as so important in specialty care settings where people are trained to really talk about substance use disorders but in primary care settings, a lot of nurses and nurse practitioners are working in primary care, maybe mental health settings, but a lot of people go into community health clinic types of settings where there isn't so much of sort of robust wraparound types of services unless you're really lucky in some way. But are you seeing changes in that in your sort of the landscape of what you've been doing for many years? What does it look like out there in community health settings? Do you feel like they're helping those patients meet those needs as well, or does it still tend to be focused mostly on medicines and referral?
Great question. I think it's as varied as the individuals and the environments. Like in certain times in the behavioral in the community healthcare setting, in the federally qualified healthcare setting, sometimes they have the best setup of all. They have
Okay.
all the resources right there, and that it's easy for patients to access financially, and that they're actually able to get very comprehensive care. And the addiction medicine is embedded in the primary care. Whereas patients in the community who are trying to use their insurance have tons of roadblocks in finding a therapist that accepts their insurance, or finding an addiction medicine doctor that accepts their insurance, or finding a psychiatrist that accepts their insurance. I think that those people sometimes are the ones that have the hardest time coordinating their care, whereas the more organized healthcare systems sometimes do
Okay.
better. So there's that. But really, just like every other aspect of healthcare in the United States, like really, there's a lot of self responsibility. Individuals, we leave it to them to try and develop, to implement the plan. I will tell you what I think you need, but then it's up to you to go out and try and find it. And I'll help you, but really, like, I can't do it for you and I can't pay for it for you. And
Right.
that makes it really, really difficult. And this is partly why we don't get the kind of outcomes that we could, because we
Okay.
don't provide treatment on demand that's comprehensive, individualized, and
Okay.
multimodal to every man, woman, and child who could benefit from
Right. Right. One thing that sort of a message for that I like people to have is that there's so much value in all these other sort of wraparound and comprehensive types of services, but the medication is also robust. So if they're working in a setting that doesn't have, all the bells and whistles and the Cadillac care that we would want, there is still huge value in them being waiver trained and being able to just get medication on board to start. Um, because there's been so many providers and even nurse practitioners that we've worked with in sort of the AAAP, the PCSS link, and that are kind of new prescribers that are like, well, I'm kind of waiting to start until we get more behavioral health on board, or I'm kind of waiting to start. And the medications are so robust that I mean, people should start and
it.
then get
Correct.
okay.
That's right. And remember, like, if any time you can take a patient who's abusing full agonists and transition them to partial agonists, you are potentially saving their life. Okay. And that really, even though we don't really want anyone to have to take buprenorphine or methadone, it beats the heck out of dying. And when you look at the data, what the data shows is that people who are on buprenorphine survive to a much greater extent than people who are abusing opioids, especially in today's climate where the illicit opioid supply is contaminated with all these fentanyl analog products, which can be so ridiculously dangerous. So I would say, we want to recommend counseling. We want to encourage counseling. We want to give people as much of the resources they need, but some is a ton more than none. And what we know is that all the counseling in the world won't save you if you don't have medication and you have severe opiate use disorder, right? I mean, like, so really, like, medication prevents relapse, it blocks craving, it prevents withdrawal, it does a lot of really powerful things. And I'm not saying that's all people need in order to have the exact best thing. That, that's not it, right? All of the above is the best. But if you could only have one thing, I'd rather have medication than therapy, or medication than group support.
Great. Great. Thank you. Um, I don't see any more questions in the chat, and we are sort of winding up here. So if you have any more questions, we just have a couple minutes left, and we're happy to have Dr. Torrington ask anything else that comes up. We really appreciate your time today. Part of the goal, as we said, is for us to kind of start to engage you in and get interest in the waiver training that Azusa Pacific is doing online, and we in 2021 we'll also be doing some kind of 50-50. And we hope to engage Dr. Torrington, who you saw today, as well as Brian Hurley from last week, to sort of help with some of that, some of the waiver training that you guys are going to be taking. And we know that nurse practitioners have an extra heavy load with those additional 16 hours beyond the 8 hours, but we hope to make it as interactive and interesting as possible. And I know that Dr. Torrington gave us a lot of good information today. Irene has the link in the chat to the evaluation, or you can scan the QR code and to get your CEs and to do your evaluation. And
I just want to get one more pitch out there to all you participants, right? I'm sorry that they've made it so hard for you to get access to this tool, but you are paving the way for those next, okay? When I first got my training, right, I was limited to only 30 patients, okay, which was heartbreaking for me because I had almost 30 patients who were left over from clinical trials who wanted the medicine, right? And I appreciate that it's very difficult, but you are groundbreakers. It's worth it. And that when you start taking care of patients with opiate use disorder with these tools, you're going to find it to be one of the more rewarding things that you do clinically, and your patients are going to be extremely grateful. So I encourage you to soldier on and plow this road, because the people behind you are going to really appreciate it.
You're groundbreakers. And Matt, I want to thank you for that pitch, because it's only been in the last few years that nurse practitioners and PAs, and there are even additional advanced practice practitioners, and I forget, like nurse midwives, or there's a few others that are able to, or soon to be able to prescribe. And you know, a lot of people will say that utilizing nurse practitioners and PAs it's critical in scaling up the way that we need to. There's just not enough physicians alone to do this work. And so it's one of the reasons why I know Azusa Pacific was so excited to get this grant, is that we really need folks like you entering the field with a level of skill and knowledge to be able to prescribe and treat this population. So thank you. And Matt, I want to give you a big round of applause. I want to thank you a lot. You're very engaging and also so knowledgeable. So we're lucky to have you. And for the rest of you, we hope to have similar kind of webinars like this in 2021. And we hope you join, because we plan to try to build this skill set and knowledge base for you as you enter the field as a nurse practitioner. So thank you. Says, thank you, Dr. Torrington, for this lecture and for letting UCLA nurse practitioners join in. This was very exciting. So good. We've got some UCLA folks on the line too. Great. Thanks, Dr. Torrington.
Okay, take care of you guys. Have a
Thanks,
wonderful
everyone.
holiday. Okay.
Happy holidays.
Bye-bye.
Thanks, Matt.